Case number 13. A 20-year-old female came with generalized lymphadenopathy. Cervical lymph node biopsy was taken. Here, lymph nodes demonstrate effacement of the normal architecture by small to medium-sized lymphoid cells, vaguely nodular growth pattern, and compartmentalization by fibrous tissue. These two photos demonstrate effacement of the normal architecture of the lymph nodes, vaguely nodular growth pattern, streaming of the neoplastic lymphoid cells out into perinodal tissues, a focal starry sky pattern. This image demonstrates effacement of the normal architecture of the lymph node, small to medium-sized lymphoid cells, that is lymphoblast, a focal starry sky pattern due to tangible body macrophages that have ingested the debris of dying neoplastic cells. It is indicative of high proliferation rate. Lymph nodes demonstrate effacement of the normal architecture, relatively uniform proliferation of small to medium-sized cells with blast morphology, a focal starry sky pattern. It is indicative of high proliferation rate. This image demonstrates effacement of the normal architecture by small to medium-sized lymphoid cells with blast morphology, that is lymphoblasts. Neoplastic cells with scant cytoplasm and convoluted to round tumor cell nuclei with dusty chromatin and small to inconspicuous nucleoli, and numerous mitotic figures. These two images demonstrate extranodal streaming by neoplastic small to medium-sized cells and vascular involvement, invasion. This image demonstrates streaming of the neoplastic lymphoid cells out into perinodal tissues and vascular involvement, invasion. This image demonstrates small to medium-sized neoplastic cells with blast morphology, that is lymphoblasts, which have a high NC ratio, scant cytoplasm, convoluted to round tumor cell nuclei with dusty chromatin, small to inconspicuous nucleoli, and numerous mitotic figures. These images demonstrate multiple vascular involvement, invasion by lymphoblasts. Immunohistochemistry. These two images demonstrate a strong cytoplasmic positivity for CD3. It is also called OKT3. CD3 OKT3 is a T cell marker. It shows cytoplasmic positivity in immature T cells, CD3, while negative surface CD3, SCD3. However, it shows complete and membranous positivity in mature T cells, SCD3. The neoplastic cells demonstrate strong nuclear, membranous, and cytoplasmic staining for BCL2, anti-apoptotic protein. The neoplastic cells demonstrate a strong diffuse nuclear positivity for Ki67, marker of cell proliferation. The neoplasm exhibits a very high proliferation index, with virtually all cells expressing Ki67. The neoplastic cells demonstrate a diffuse strong nuclear positivity for TDT. The TDT is a blastic marker that is expressed in most precursor lymphoid neoplasms. These two images demonstrate a strong cytoplasmic positivity for CD5. CD5 is a T cell marker. CD5 is important in identification of T cells and most T cell lymphomas, some B cell lymphomas, such as CD5 positive diffuse large B cell lymphoma and thymic carcinoma. These two images demonstrate a strong cytoplasmic positivity for CD4 OKT4 with membrane accentuation. CD4 OKT4 is a common T helper cell marker used to classify lymphomas. It is positive for many post-thymic T cell leukemia lymphomas and T cell lymphoproliferative disorders. These two images demonstrate a strong cytoplasmic positivity for CD7. CD7 is a T cell marker used for malignant immature T cells and CD7 positive stem cell lymphoma. CD7 is a very good marker for T acute lymphoblastic leukemias. TDT and CD5 immunostaining highlights the intravascular and perivascular invasion by the neoplastic lymphoid cells, pre-T cells, lymphoblasts. The lymphoblasts are -4, CD20, a common B cell marker, CD79A, a pan B cell marker, approximately 50% could be positive, CD1A T cell surface antigen marker, CD8 OKT8 cytotoxic T cell marker, BCL6 marker of germinal center differentiation, MUM1IRF4 marker of non-germinal center B cell-like lymphomas, or CD34, a marker for hematopoietic progenitor cells, blasts. Okay, what is the diagnosis? It is T-lymphoblastic lymphoma leukemia. Okay, let's talk about T-lymphoblastic lymphoma leukemia. General background. T-lymphoblastic lymphoma leukemia is an aggressive neoplasm of immature lymphoid cells, that is, lymphoblasts, committed to the T cell lineage, that is, pre-T lymphocytes. The disease usually presents as an extramedullary tumor mass in the anterior mediastinum or lymph nodes. A smaller subset of patients present with predominant blood and bone marrow involvement, T-lymphoblastic leukemia. Patients with T-lymphoblastic lymphoma leukemia are most often adolescents and young adults. A male to female ratio is 2:1. Patients commonly present with widespread supradiaphragmatic lymphadenopathy and or an anterior mediastinal mass, thymus. Peripheral blood involvement is seen in approximately 1/3 of patients at time of presentation. Different cytogenetic abnormalities are cryptic and identified only by FISH or PCR. The most frequent gene partners are HOX11, TLX1 at 10q24 and HOX11L2, TLX3 at 5q35, with many other partners including TAL1, 1p32, and MYC. Prognosis and therapy. In the pediatric age group, B lymphoblastic lymphoma leukemia patients generally have a better outcome than those with the T lymphoblastic lymphoma leukemia. Adult patients with the T lymphoblastic lymphoma leukemia appear to have a better outcome than those with B lymphoblastic lymphoma leukemia using current therapies. Chemotherapy cures 60%. Patients have earlier relapse, induction failure, isolated CNS relapse compared to pre-B lymphomas leukemias. Thank you.